Hello class, we are going to talk about disaster preparedness and emergency care today. After this lecture, you'll be able to identify the 5 levels of the Emergency Severity Index, or the ESI. You'll be able to describe the difference between hot and cold related emergencies and the treatments related to each, and develop strategies to triage a patient in the event of a disaster, a mass casualty incident, or the emergency room setting using the Emergency Severity Index. The first thing we're going to talk about is the emergency room setting, and we're going to talk about the triage system that is used there called the Emergency Severity Index. So the triage system literally is to identify and categorize patients so that the most critical are treated and seen first. This process is to sort or process to rapidly determine patients by their acuity. So this is not a first come, first serve basis when a patient comes in and checks into the emergency room. They would come, check in, and then they're going to sit down with a triage nurse, and that nurse, based on the patient's presenting symptoms, vital signs, mechanism of injury, and such, will assign this patient a ESI number. And then that number will then group them into a category, which will determine how quickly they will be seen. This is a 5-level triage system that includes a triage algorithm that will help to assign them the triage level. It's supported by the Emergency Nurse Association and the American College of Emergency Physicians. It incorporates concepts of illness severity and the number of resources that are going to be used to determine who should be seen first. So like I said, it's a ESI 1 through 5. So a patient who qualifies for an ESI level 1, this person is going to have an immediate threat to their life. So you need to ask yourself, is this patient in imminent danger of dying? Have they presented unconscious, not breathing, no pulse, and in need of CPR? And they're likely to use all of our resources immediately. That would be an ESI level 1. And I'm going to break down for you all the algorithms associated with each of these. ESI number 2, this is a high-risk patient who should not wait to be seen, and they are likely to need to be seen within the next 10 minutes. We're talking our strokes, our STEMIs, maybe a septic patient, really critical, high acuity patient. Now our ESIs 3, 4, and 5 are going to be based on the number of anticipated resources needed. So let's start to break these down by algorithm. And we're going to start by talking about vital functions, okay? So if they're an ESI 1, their vital functions are completely unstable. If they're qualified as an ESI 2, their vital functions are threatened, but relatively stable. An ESI 3, 4, or 5, they are likely to have their vital functions, their ABCs, are stable. Is there a threat to their organs or their life? If they are an ESI 1, there is an obvious threat to their life or organs because they're not breathing or their heart's not beating. If they're an ESI 2, it's likely, but not always obvious. So if they're having a stroke, that could be life-threatening. If they're having a STEMI, that could be life-threatening. Strokes can cause organ damage. ESI 3, it's very unlikely that this is going to be a life-threatening illness or cause a threat to their organs, but it's possible. ESI 4, there's no threat to life or organ. ESI 5, there's no threat to life or organ. How soon should the healthcare provider see the patient? If that person needs to be seen immediately because we're doing CPR, that's an ESI 1. If they can wait 10 minutes, like we can triage them, bring them back, sit them in a bed, go find a provider, and they're going to be okay while we walk away from them for 10 minutes, they're an ESI 2. ESI 3s can wait up to an hour. ESI 4s and 5s, they can be delayed. They can wait 3, 4, 5, 6 hours in the waiting room if needed, and their condition is unlikely to change. So now we talk about the number of resources that are expected. For an ESI level 1 person, there is a high resource intensity. There's a number of staff at the bedside continuously, and there's often a mobilization of team responses. So this is a high level of resources, all of our resources really. In ESI level 2, this is also a high resource intensity, multiple, often complex diagnostic studies, frequent consultations, and continuous monitoring. Maybe even a one-to-one nurse might be needed. ESI level 3, this could be medium to high resource intensity. We're talking multiple diagnostic studies like maybe labs, x-rays, brief observations, complex procedures like IV fluids, IV push drugs. And ESI 4 would be low resource intensity, like one simple diagnostic study. Maybe they sprained their ankle, and we're going to do one x-ray to make sure it's not broken. So this is one simple procedure. Or they have a small laceration and they're going to need sutures. That would be one simple procedure. An ESI level 5 is the lowest resource intensity, and this is going to be an exam only. They're not going to have any diagnostic studies done, no x-rays, no procedures, just an examination. This would be coughs, colds, and prescription refills. Some examples for each ESI now that you have a little bit more of an understanding of what we're looking for each ESI category. For an ESI 1, this would be our cardiac arrest, an intubated trauma, an overdose with bradykardia, and severe respiratory distress. Our ESI 2, right? Chest pain from ischemia, multiple traumas, unless they're responsive. STEMIs, strokes, sepsis patients. ESI 3, abdominal pains, gynecologic disorders, severe hip fractures. This can also be kidney stones. ESI 4, closed extremity traumas, so fractures, simple lacerations, maybe cystitis or UTIs, uncomplicated UTIs, not uroseptic UTIs. ESI 5, cold symptoms, a minor burn, a recheck. So if we have a patient that had sutures a couple days ago and we've asked them to come back in just to have the wound checked and redressed, that would be an ESI 5. A prescription refill. So a patient, say they ran out of their psych meds and it's Friday afternoon and they cannot get a hold of their doctor and it's a holiday weekend. So they're not going to be able to get a hold of anyone till Tuesday. And so they've parked themselves in the emergency room, waiting room, waiting for a prescription refill. They're going to get an ESI 5 and they're going to be at the very end of the line. They're going to wait as long as they need to wait to get that prescription refill. Another very popular use of the emergency room, which was a lot of ESI 5s during COVID, was that people would test positive for COVID in like 2020, 2021, and they would need a doctor's note in order for their employer to give them time off. And they couldn't get into their doctor's offices. So they would come to the emergency room, they would need to get a swab and a doctor's note proof that said they had COVID, and they were asymptomatic. That would be an ESI 5. Now say we have that ESI1 or ESI2 patient and they're coming in and they're a trauma. So we're going to talk about how to care for a trauma patient. Every trauma patient that comes in, there is a systematic evaluation that takes place that helps everyone kind of gather their thoughts and go through this head to toe systematic process to make sure nothing gets missed. So we have a primary survey and a secondary survey, and you do need to know the difference between both. So starting with the primary survey, this covers, you can remember the mnemonics A, B, C, D, E, F, and G. A is for alertness, airway, and cervical spine stabilization. B for breathing. C for circulation. D for disability. E for exposure and environmental control. F for facilitate adjuncts and family. And G is get resuscitation adjuncts. And we're going to talk about each one of those quickly here. The only time the process changes is if someone is having a catastrophic hemorrhage. And then that prioritization of ABC changes to CABC. You have to take care of a catastrophic hemorrhage first. You have to stop the bleed. If you don't stop the bleed, you're going to do CPR and that person's just going to continuously bleed out onto the sidewalk and you're not going to get recirculation or reperfusion. So you have to apply direct pressure followed by pressure dressing to the obvious bleeding sites. That has to be controlled first, and then you can move on and continue your ABCs. So A stands for alertness and airway. While you're assessing the alertness and the airway, you need to be stabilizing the cervical spine at the same time. So even though that doesn't kind of fall into the, A, you need to remember that at the same time while you're looking at their alertness and their airway, you are stabilizing their cervical spine, whether that is with a cervical collar, if you happen to have one because you're in the medical facility, or if you are out in the field, you would be using rolled shirts or a towel or a blanket or whatever it is to stabilize their neck. Nearly all causes of immediate traumatic deaths are from airway obstruction, and airway obstruction sources can be saliva, bloody secretions, vomit, laryngeal trauma, even dentures falling back into the mouth, facial traumas, and fractures. Patients at risk for airway compromise are from seizures, drowning, anaphylaxis, foreign body obstructions, and cardiopulmonary arrest. When you're assessing for alertness, you could determine their level of consciousness and determine correct airway interventions. Assess the patient's response to their verbal or painful stimuli. I don't know if you remember the acronym AVPU, AVPU, and that stands for alert to voice, pain, or if they're unresponsive. And so that's just a quick mnemonic to remember how to assess for their level of consciousness. Make sure you stabilize that cervical spine with manual stabilization, a rigid cervical collar if you have one. Keep the head of the bed flat and continue to monitor their airway and breathing. B stands for breathing. So breathing changes may occur with fractured ribs, pneumothorax, a penetrating injury, allergic reactions, PEs, asthma attacks. So we're assessing for that dyspnea, asymmetric chest wall movement, decreased or absent breath sounds, visible wound or chest wall injuries, cyanosis, tachycardia, hypotension. C stands for circulation. So there's a risk for hemorrhagic shock with uncontrolled internal or external bleeding. So hopefully we've already got that under control if we're going through our CABC, if that's the case. Assess for quality and rate of carotid and femoral pulses. Peripheral pulses may be absent because of injury, vasoconstriction, right? Everything goes to your core. Assess skin temperature, color, and moisture. Assess for signs of shock like mental status changes, confusion, and check for those delayed capillary refills. And so that's your circulation. Also, if you are in the ER, we're inserting 2 large bore IV catheters. Use the upper extremities if contraindicated, and if we absolutely cannot get IV access, then we can use the intraosseous or central veins. Initiate aggressive fluid resuscitation using normal saline or lactated Ringer solution. We can also do blood products and packed red blood cells using O negative for emergency transfusions, as that's the universal blood type. D stands for disability, and so we're checking for that neurologic status, any measure of disability there with their level of consciousness. We can do that by using the Glasgow Coma Scale. It's standardized for consistent communication among the care team. It's not accurate with intubated patients or aphasic patients at baseline. We're also checking for their pupils, the size, shape, equality, and reactivity. E stands for exposure and environmental control. So remove clothing to perform physical assessment. Don't cut through any forensic evidence. You need to be very aware of that, depending on what the trauma is that's bringing them in. Do not remove any impaled objects. Prevent hypothermia by applying warm blankets, warm IV fluids, and overhead warmers. Maintain privacy. Obtain their vital signs, pulse ox, and BP in both arms. F stands for facilitating adjuncts and family. Family can be present during resuscitation and invasive procedures. They can stay in the room while we're doing CPR. It benefits the patients, the caregivers, and the staff. It provides comfort, advocate for the patients, remind staff of the person behind the trauma, and assign someone to explain care and answer questions to the family. It's great to have a family liaison, someone that's just focused on the family and answering their questions, so that people who are trying to provide care are not also distracted in trying to answer the family's questions when the family is in the room. G stands for Get Resuscitation Adjuncts to help you with LMNOP. So G, Get Resuscitation Adjuncts, and then LMNOP. So L stands for laboratory tests. We're going to get labs. M, monitor ECG. N, nasogastric or orogastric tube if needed. O for oxygen if they need it. And P for pain management, pharmacologic or non-pharmacologic as needed. Once we have all of that done, the patient's considered hemodynamically stable, and we can move on to the secondary survey. This all happens very, very quickly. So the primary survey will be done within minutes. The secondary survey will then be started. This is a brief, systematic process to identify all the injuries. So now we're going to get a history and a head-to-toe assessment. We want a history of the mechanism of the injury or the illness from the patient, the caregivers, the friends, the bystanders, or the emergency personnel that brought them in. Tell us why they're here. If it was an automobile accident, tell us where they were seated. Did they have their seatbelt on? How fast were they going? Or were they a passenger in the car? And at the same time, we're going to be doing a head-to-toe assessment, starting with the head, the neck, the face, moving to the chest, the abdomen and the flanks, pelvis, the extremities, and then roll them, which would be a log roll, and inspect the posterior surfaces. SAMPLE is another acronym that you should remember. SAMPLE in the secondary survey stands for symptoms, allergies and tetanus status, medication history, past medical health, last meal, and events or environmental factors that preceded the illness or injury. So those are all kind of the things that we're looking for as we're getting a brief, quick assessment from the other people around the room. And then as you're going through that head to toe, you're noting the general appearance as you're looking at their face, their neck, and their head. You're assessing for any lacerations, deformities, tenderness, bleeding, hematomas, drainage, ecchymosis, edema, any foreign bodies, any battle signs or raccoon eyes that may indicate skull fracture. You want to assess neck for stiffness, pain in the cervical vertebrae, any tracheal deviation, distended neck veins, any difficulty swallowing, any subcutaneous emphysema. Moving on to the chest, you want to observe their respiratory rate, their depth, and effort. Note if their chest wall movements are symmetrical and use if they're using any accessory muscles. You want to palpate for any subcutaneous emphysema. It's also called crepitus. Auscultate the breath sounds. You're listening for a pneumothorax. You're also going to palpate for any rib fractures, pulmonary contusions, or any blunt cardiac injuries. And you also want to assess for hemothorax. We also want to obtain a chest x-ray, an ECG, and we're going to be just looking and inspecting for any external injuries. As we continue to move down to the abdomen and the flanks, we're evaluating frequently for any subtle changes. If there is any blunt trauma, if there's any penetrating trauma, remember not to move any objects. We're inspecting for any external signs of injury, but you want to auscultate the bowel sounds, palpate for any masses. If the patient reacts with any guarding, and you're going to check for femoral pulses. Moving on to the pelvis and the perineum. We're going to inspect and gently palpate the pelvis, but do not rock the pelvis. Any pain may indicate that there's a pelvic fracture, and we definitely want to get imaging for that first. We don't want to rock the pelvis if there's any fractures there. We're going to assess the genitalia for any bleeding, bladder distension, any hematuria or dysuria or inability to void. We'll probably put a Foley in at this point. The rectal exam may be performed by the healthcare provider to check for rectal tone, especially if there's any kind of suspicion of a spinal cord injury. The extremities would be inspected next, observed for any external injuries, evaluate the movement, strength, and sensation of each extremity. You're going to be checking for symmetry as well. Point tenderness, any crepitus, any deformities. Immobilize and splint and elevate any injured extremities and apply ice packs. Check pulses, especially distal pulses if there are any injuries to that extremity. A pulseless extremity is a time-critical emergency. We're checking for compartment syndrome. That would compromise the viability of muscles, nerves, and arteries. So that is also a medical emergency and needs to be taken care of right away. After the extremities have been inspected, then we would log roll the patient. And log roll requires 3 to 4 or sometimes more if the patient is very obese to protect the cervical spine. Inspect and palpate along the spine, starting at the top and all the way down the bottom for any deformities, bleeding, lacerations, or bruising. Palpate the entire spine and at the same time inspect the back. After all of this is done, acute care and evaluation, we need to evaluate the need for tetanus prophylaxis, provide ongoing monitoring, and evaluate the patient's response to any interventions that are needed. Monitor their airway breathing, their vital signs, their level of consciousness, pulses, skin color, temperature, and moisture. Insert that indwelling catheter if we haven't already. And then prepare to transfer them for diagnostic testing unless we have portable x-rays and things coming to us, or transport them to the OR, or admit them to the general unit or telemetry or intensive care unit, or even transfer them to another facility. So that's our very systematic way of receiving a trauma patient, going through the primary survey first, immediately going into the secondary survey, and then just really doing a brief but systematic head-to-toe assessment all at the same time. And it happens very rapidly, even though it sounds like a lot when we're talking about it and when I'm going over all of it in a PowerPoint, it sounds like a lot of information. But in real time, it happens very quickly, very systematically, and it flows really well together. Moving into the next section, we're going to talk about heat and cold related emergencies. So a heat-related emergency is a brief exposure to intense heat or prolonged exposure to less intense heat that can lead to a heat stress. This occurs when thermoregulatory mechanisms cannot compensate for exposure to higher ambient temperatures. An ambient temperature is a product of an environmental temperature and humidity. So a heat-related emergency happens when their core body temperature rises within 10 to 15 minutes higher than 105.8 degrees. This can cause altered mental status, confusion leading to coma, hypotension, tachycardia, tachypnea, weakness, hot, dry skin, and absence of perspiration. A heat stroke is the most serious form of heat stress. It's a medical emergency. The brain is extremely sensitive to thermal injuries and can lead to cerebral edema and hemorrhage. So death is related to the amount of time the patient's body temperature remains high. So it's really critical that we bring that body temperature down really quickly. We need to stabilize the ABCs and rapidly lower that body core temperature by removing clothing, cover with sheets, even spray with lukewarm water and place the patient in front of a large fan. Immerse in a cool water bath if possible. Now, shivering increases core temperature and complicates the cooling effort, so we may administer some drugs to help control shivering. We're going to monitor for dysrhythmias. A cold heart is an unhappy heart, and so bringing hearts from one extreme temperature to another can cause dysrhythmias. Administer 100% O2 and ventilate with a bag valve mask or intubate with mechanical ventilation if needed. Continuous ECG monitoring and pulse ox monitoring is required, and we want to monitor labs and correct any electrolyte imbalances or coagulation abnormalities that occur. Insert a Foley catheter to monitor for any rhabdomyolysis. So we're checking the urine color, amount, pH, and for any myoglobin in the urine. That might indicate that there's rhabdo going on. Some of the reasons why people might end up in a heat stress or heat stroke situation may be someone who's in a situation where they're unhoused and they have no choice but to carry all their belongings with them. And so they're wearing many layers of clothing, walking around on a very hot day, and causes them to overheat very quickly. Another example might be marathon runners running on a very hot day and having inadequate hydration. So there are very many reasons why someone may overheat, or someone using a hot tub on a very hot day, like an outdoor hot tub on a very hot day. So talking about some cold related emergencies, and specifically frostbite. So there's superficial frostbite, which is on the skin and the subcutaneous tissues. It affects the ears, nose, fingers, and toes most often. It makes the skin appear a waxy yellow or a blue to molted kind of coloration, and it can feel kind of crunchy and frozen. Tingling, numbness, and burning might be some of the presenting complaints, but never squeeze, massage, or scrub the injured tissues. So what happens with this superficial frostbite is the tissues under the skin actually crystallize, and when you massage them or squeeze them, you can break down the crystals and like shatter them, and it actually breaks down their tissues. So swelling will occur with thawing. So you want to make sure you remove any restrictive clothing or jewelry. As the person thaws, they will swell. The first thing you really want to do is immerse the affected area in circulating water that is 98.6 to 104 degrees Fahrenheit. You don't want to have them in standing water. You want them really in circulating water. Use warm soaks for the facial areas because, of course, we're not going to dunk somebody's face in circulating water. So using warm facial soaks would be best for the face. The areas are going to feel warm and sting as it thaws, so they're going to have a lot of reperfusion pain. Blisters are going to form within hours. We want to really avoid any heavy blankets and clothing to the area. Rewarming is so painful, so we want to make sure we give analgesics and provide tetanus prophylaxis if needed. And we want to evaluate them for systemic hypothermia as well, depending on what they came in for. Then there's deep frostbite, and this really involves the muscle, the bone, and the tendons. So the skin is white, it's hard, it's insensitive to the touch. They really don't feel any pain. This can progress into gangrene. Again, you want to immerse this into temperature-controlled circulating water, 98.6 to 104 degrees, until flushing occurs distal to the injured area. What that means is if there is frostbite, deep frostbite that's happening maybe on someone's wrist, but their fingers don't have that frostbite, you want to look for flushing in the fingertips, anything that's distal to the area where the injury is. After rewarming, you're going to elevate to decrease the edema after the rewarming. Significant edema is going to occur within 3 hours, and blistering is going to occur in the next 6 hours to the next couple of days. So IV analgesics and NSAIDs are going to be needed. Amputation may be required if this is on fingers and toes, and hospitalization may be indicated just to help with pain control, and then obviously if there's surgical procedures needed. Now, aside from frostbite, talking about systemic hypothermia, if someone has a core body temperature lower than 95 degrees, this can be considered a cold-related emergency in hypothermia. This is when the body heat produced is less than the body heat lost. Now, most body heat is lost through radiant energy, especially from our head, our thorax, and our lungs. There's some evaporated heat loss, which increases 5 times greater than normal with wet clothing on, and it increases to 25 times greater than normal when you're immersed in cold water. Heat conservation and production happens. There's peripheral vasoconstriction, so everything kind of comes to the core center of your body to help your vital organs. And then there's shivering, which will also help. Shivering and movement. If you've ever been cold here in the winter, which I'm sure most of you have, you shiver when you're cold, but also you may like shift your body from foot to foot and just kind of can't stop moving. And that's another way your body just naturally tries to help you produce a little bit of heat. Predisposing factors to this would be exposure to freezing temperatures, cold winds, wet terrain, physical exhaustion, inadequate clothing, and inexperience. So unfortunately, we might see this with someone who is hiking a mountain in the winter without adequate clothing because maybe they've come from Arizona and they're here visiting and they're just not familiar with what winters can be like. It could be someone who is out on the ice and the ice is just not thick enough and they're on an ATV and they've now gone through the ice. Inadequate clothing could also be for children. I know my children, it is a tough time to try to get them to wear a winter coat and sometimes even a sweatshirt in the winter just to cover their skin so their skin is protected. Mild hypothermia is that 93 to 95 degree Fahrenheit range where you're going to see the person present with some shivering, lethargy, even some confusion, and they're going to be, they could be irrational behaviors because of the confusion. They could have some minor heart rate changes because, again, the heart doesn't like to be cold, and cold blood coagulates and can cause some dysrhythmias. Moderate hypothermia, 86 to 93, they're going to be pretty rigid, bradycardic. The BP may be only obtainable by Doppler. Their blood is going to be very sludgy and slow. Their metabolic and respiratory acidosis, hypovolemia, and their shivering decreases or disappears as core body temperatures reach 86 degrees. So they just really start to shut down. As core temperature decreases, the metabolic rate decreases 2 to 3 times. So cold myocardium causes dysrhythmias. The decreased renal blood flow causes the GFR and decreased water absorption, leading to dehydration. Increased hematocrit causes decreased intravascular volume. Cold blood is thick and acts as a thrombus, so now we worry about clots. Decreased blood volume, blood flow leads to hypoxia, anaerobic metabolism, lactic acid accumulation, and metabolic acidosis. So the blood's just not flowing well enough to bring all that oxygenation around, and it's sitting and accumulating and leaking that lactic acid and the renal acids. So this is a potentially life-threatening situation. If someone has severe hypothermia and their temperatures reach below 86 degrees, this person probably appears dead. They may even have undetectable vital signs, absent reflexes, and their pupils might be fixed and dilated. You might see some bradycardia, VFib, or pulseless electrical activity on the monitor, but every effort has to be made to warm this patient to at least 86 degrees before they can be pronounced dead. And it is possible once they are rewarmed above 86 degrees to get their blood flowing again and resuscitate this patient, which is why they cannot be pronounced dead until they are warm and dead. Treatment of hypothermia: remove them from the cold environment, manage and maintain their ABCs, provide oxygen, IV access for fluid resuscitation, and then there's passive and active rewarming. So passive rewarming would be things that you can just do that anyone can do. Remove their wet clothing, apply dry clothing, use warm blankets or radiant lights. Active rewarming, these are things that we really need to do in a hospital setting, like warmed fluids, the air-filled warming blankets like the bear huggers, warm water immersion with ECG monitoring, heated humidified oxygen, warmed IV fluids, peritoneal lavage with warmed fluids in extreme cases, correcting their dehydration and acidosis, and then monitor and treat dysrhythmias. Now we're going to talk about mass casualty incidents and disaster-related emergencies. There's a historical perspective of disasters in the United States that they could be acts of God or attributed to God's dwelling within various places. They could be caused by wars and civil disturbances or by severe weather like blizzards, tornadoes, and hurricanes. There's 3 different phases of disasters, and you do need to know each phase. There's the pre-warning phase of the disaster. This is when preparations for possible evacuation, mobilization of resources, and review of community disaster plans happens. The next phase, the disaster event occurs. This is when the provision of resources, assistance, and support as needed happens. The third phase is the recuperative effort. This is when strategies for healing the sick and injured and preventing complications from health problems, repairing damages, and reconstructing the community happens. So pre-warning of the disaster, disaster event occurs, and recuperative effort. Different types of disaster victims. There are victims who may or may not survive. Victims who survive with injuries are more likely to experience depression, PTSD, anxiety, and other mental health problems. Other victims of disasters are the professional rescuers, who often experience psychological effects of being at the scene, and then everyone else involved. So, family members, bystanders, children, most experience some psychological stress. So, our mental health assessment of patients who are a victim of a disaster include knowing the ages of the victims, their gender, their capability to participate in problem-solving activities related to the devastation, and their level of self-confidence or self-esteem. So we want to know what they're like, how resilient they might be. We want to monitor news media's impact on their mental health of the victims. We want to assess the difference in response depending on the gender and age. And then there's high-risk victims like children and adolescents for mental health problems. So victims may suffer from various mental responses. Victims are at high risk for future mental health problems. They may experience traumatic bereavement. We want to assess for behaviors which may indicate a mental disorder and assess coping strategies used by each victim. So terrorism and other related emergencies. Terrorism involves the overt action or express purpose of causing harm, and this could be by bioterrorism, which is a disease pathogen, or using a chemical agent, or radiologic or nuclear or explosive devices. Now, bioterrorism, some examples could be anthrax, botulism, the plague treated with antibiotics, assuming sufficient supplies are available. Smallpox can be prevented by vaccination, even when first given after exposure. Different chemical agents of terrorism. There's sarin, which is a toxic nerve gas that can cause death within minutes of exposure. It enters the body through the eyes and the skin, and it acts by paralyzing the respiratory muscles. So antidotes for nerve agents are atropine. There's phosgene, which is a colorless gas that's normally used in chemical manufacturing. And if it's inhaled at high concentrations for a long enough period of time, it causes severe respiratory distress, pulmonary edema, and death. And then mustard gas, which is yellow to brown in color with a garlic-like odor. It irritates the skin and causes skin burns and blisters. When water mixes with mustard gas, it releases a chlorine gas, which makes it especially difficult if someone's brought into a decontamination tent and sprayed down with water. It releases a chlorine gas and then causes problems for people who are trying to help as well. Radiologic dispersal devices, or RRDs, are also called dirty bombs. This is a mix of explosives and radioactive material, and when it's detonated, the blast scatters radioactive dust, smoke, and other materials into the environment, resulting in radioactive contamination. The main danger from RRDs is the explosion. Ionizing radiation from nuclear bombs or damage to nuclear reactors is a serious threat to safety of casualties in the environment. Exposure may or may not include skin contamination with radioactive material. Typically, explosives that are used as agents of terrorism result in one or more following types of injuries: blast, crush, or penetrating injuries. Blast injuries from a supersonic or overpressurized shockwave that results from an explosion can cause damage to the lungs, the middle ear, or the gastrointestinal tracts. So emergencies are any extraordinary event that requires the rapid and skilled response that can be managed by a community's existing resources. When we define something as a mass casualty incident, this is a man-made or natural event or disaster that overwhelms the community's ability to respond with existing resources. So again, an emergency is any extraordinary event that requires a rapid and skilled response that can be managed by a community's existing resources. Like they don't need any outside help. But when a mass casualty incident occurs, this is when an event happens that overwhelms the community's ability to respond with existing resources and they need help. When an emergency or a mass casualty incident occurs, first responders like police, emergency medical personnel are dispatched. And a triage of casualties differs from the usual emergency room triage. This is conducted in less than 15 seconds. This is a field triage. In the emergency room, we talked about the different ESI numbers, 1 through 5. Now we're going to talk about field triage, and this occurs in colors. The colors we're going to talk about are green, black, red, and yellow. Green are people who are moving, walking wounded. They can bring themselves to the emergency room if they needed to. People who are tagged black are deceased or likely to die very soon. Red are people who need to be seen immediately. They're going to be the first people loaded on the ambulance. They may be breathing but unconscious or have respirations over 30. They may have penetrating wounds or serious injuries, but they're going to survive, but they need help right away. And then people who are yellow are people who are going to be able to have delayed care, fractures, things of that nature. We're going to talk about that. So green is your minor injuries, yellow is your non-life-threatening, non-critical injuries, red is your life-threatening injuries, and black identifies your dead or likely to die. If there's known or suspected contamination, like bioterrorism, you want to decontaminate at the scene. You're not going to take everyone to the hospital and decontaminate there. You're going to decontaminate at the scene. Many casualties will arrive to the hospital on their own, such as the walking wounded. These would be your green tagged people. The total number of casualties that a hospital can expect is estimated by doubling the number of casualties that arrive in the first hour. Generally, 30% of those people will require admission to the hospital, and half of them will require surgery within 8 hours. Communities have initiated programs to help community emergency response teams. Community emergency response teams are partnered in emergency preparedness, and training helps citizens to understand their personal responsibility in preparing for natural and man-made disasters. All healthcare providers have a role in emergency and mass casualty preparedness. Knowledge of the hospital's emergency response plan and participation in emergency and mass casualty incidents preparedness drills is required. And that is the end of this lecture.